This 13-year-old female patient was referred to me for evaluation of tooth number 8. This tooth was traumatized a few years ago, and as you can see, part of the tooth got chipped off. She was taken to her dentist, and her dentist filled the tooth, but not realizing that there was pulp exposure. Fast forward a few weeks ago, she started to have some symptoms and then noticed this. Right here, there's a labial parielis sinus tract associated with the tooth. That's the tooth right here. So this is draining the apical abscess. So she was taken to her dentist, and her dentist told mom and patient, yeah, this tooth is abscessed. Patient has dental phobia, so she was referred to us for evaluation and possible IV sedation RCT of tooth number 8. So I examined the tooth. There was slight mobility, I would say, Miller class 1 mobility associated with the tooth. Percussion tender, palpation tender. You saw the labial sinus tract parielis associated with the tooth, and of course probing 1 to 3 millimeters all around, and you can see a large periapical lucency, huge and wide open apex right there. So I discussed options with mom. The preferred treatment of choice would be endodontic treatment. We'll go ahead and do the root canals, IV sedate her, of course, and do the root canal for her. But I will prepare the tooth for a possible future apical, which means I would place an MTA plug here. So MTA plug will do a couple of things. One is, of course, it seals when the apical diameter is this large. It seals, gives you a better apical seal. And the other thing, of course, is that when you have to do an apical, then you're good to go. There's no need for you to retrofill, retroprep and retrofill. It's all already done. So you go ahead and remove this lesion there, resect the apical few millimeters of the root, and you're good to go. So mom agreed. So take a look here. So today she came back with mom, and we went ahead and IV sedated her and did the root canal. Endoaxis was made, and we noticed purulent discharge from the canal. I use a surgical microsuction. I placed the surgical microsuction. The working length was 21 millimeters, so I placed my surgical microsuction 1 or 2 millimeters beyond the working length, and I was able to evacuate a lot of purulence. Irrigated copiously with 6% sodium hypochlorite, and used sterile paper points to make sure that the canal was dry. Multiple sterile paper points taken to working length, removed, inspected. Canal was dry. We went ahead and placed our MTA plug. If you haven't placed an MTA plug in a case such as this one, it's not easy. It's challenging. There's no apical stop, so you could put gram after gram of MTA, but not be able to fill the canal, because what you're doing is you're literally pushing all of that MTA out of the canal. So you need to be really careful. You need to know what you're doing. You need to have the knowledge, expertise, experience of how to place an MTA in a situation like that. So this was my mid-treatment radiograph. I just wanted to make sure that I didn't have any voids in my MTA. I use white MTA. White MTA doesn't stain. This being an anterior tooth, you don't want it to stain, so that's white MTA. As you can see, MTA is placed perfectly to working length. And once we established that I don't have any gaps in my MTA, we went ahead and placed our gutter perchance sealer. Obturated the rest of the canal with gutter perchance sealer. Take a look. So this is the final product, MTA plug, gutter perchance sealer, and we went ahead and placed the permanent buildup as well using composite. The patient is already sedated. The tooth is isolated perfectly with a rubber dam, so why do temporary? I wish I could do all the permanent buildups myself instead of referring the patient back to their dentist for the dentist to do it, but politics involved, and most general dentists prefer that they did the permanent buildup themselves. In this case, because of patient being sedated, dental phobic, we went ahead and placed the permanent buildup as well. Everything went great. Again, talk to mom, advise mom to bring her daughter back in 6 months, so we can make sure that this is going away. If this periapical lucency is healing, which means it's getting smaller, that's great. What we did worked perfectly. If not, we would have to do an apical. Again, the tooth is ready for an apical. Apical is so much easier if we ever have to do it. Mom agreed, so I'll keep you guys posted. When mom brings the patient back in 6 months, I'll post that video.